be here, and thank you for your nice introduction. So I'm going to talk about challenges in treating neonatal seizures, development of novel therapies, and guidelines. So when I started working on the talk, I wasn't quite sure what was expected of me. So I emailed Andy, and he said, anything newer than phenobarbital and phenytoin will be great. And so it's a challenge for me, and we'll see where I get you. These are my disclosures, and I would also like to ask you not to make any photos or videos of the babies I'm showing in this presentation. So I'll give a very brief introduction on neonatal seizures and then talk in more detail about the challenges of drug development for neonatal seizure treatment, new guidelines, including the evidence we have for the drugs we use, and then talk a bit about the gaps that are still existing. So neonatal seizures are common. Seizures are actually more common in the neonatal period than at any other time in life. But in contrast to seizures in older children and adults, they are acute symptomatic or acute provoked seizures. So not the beginning of an epilepsy syndrome, but due to an acute insult, usually HIE, infections, vascular insults. The problem is that the clinical diagnosis is really difficult. And here you have two babies, one here with these mouthing movements. Many babies with HIE have these mouthing movements and they are not seizures, but very rarely, sometimes they are, and in this baby, they are seizures. Here is a baby with very clear clonic movements, but they are so subtle that even though they are easily diagnosed clinically, if you look, they're easily missed on a busy ITU. So really you need EEG or AEG to diagnose seizures. Therapy, I'm going to talk more about the challenges of treating neonatal seizures, but before I go there, I want to talk about the outcomes. So we know that neonatal seizures are associated with poor outcome, and the reasons for that are multifactorial. So you have etiology plays a very, very important role. Both the etiology and the comorbidity affect outcome. But we also know that socioeconomic factors influence outcome. And now there are more and more evidence that the seizure burden itself can also worsen outcome. And the anti-seizure medication we use affect the seizure burden, but on the other hand, there's some evidence or some suggestion that they may also have an effect on long-term outcome, although this hasn't been proven. So a seizure burden, if you have a high seizure burden, then that is associated with worse outcome. This has been shown in a number of studies, most clearly with status epilepticus. So if a baby goes into status epilepticus, more than 50% of seizure activity, then that is very clearly associated with worse outcome. So the status itself has an impact. But now there have been a number of studies in recent years which have shown that actually from a seizure burden of 10 to 12 minutes per hour, that itself is associated with worse outcome. So the question is whether if we treat seizures, can we avoid babies having a high seizure burden? Does the treatment itself improve outcome? And it's a really difficult question because the only way to prove this with certainty is if we have a big cohort of babies, we treat half of them, we don't treat the other half, and we look at outcome at 2 to 6 years. This is a study in principle that would answer the question, but it's not ethical, and neither the EMA nor the FDA would allow such a study. I mean, they have said this very clearly. So we can't do this. There is, however, some indirect evidence that early treatment might reduce seizure burden. So these are studies which have looked, if you diagnose early and treat early, better you can reduce the overall seizure burden. And these studies here have done exactly that. So they implemented early diagnosis with continuous EEG monitoring and then treated the seizure as soon as they were seen. And what they found is that in total, they found 20 to 30% of babies with high risk have seizures. But if you treat early, then you have less progression to status epilepticus. The babies respond better to treatment and have an overall shorter stay on the NICU. So here, this is the Harris study, and they implemented a EEG monitoring and a protocol, a treatment protocol. And what they found is that the number of babies progressed to status epilepticus was higher pre-implementation than post-implementation. This study by Courtney Wusthof looked at if you monitor babies and screen for seizures rather than confirm seizures by doing an EEG if you have a clinical suspicion, then again, you can improve the reactivity, the responsiveness to anti-seizure medication. So these are babies screened for EEG, and you have a responsiveness in 40%, and these are the babies where only confirmatory EEG was done. So when there was a suggestion of seizures, and you have a responsiveness of less than around 20%. So clear improved responsiveness to medication if you treat early, which means that the treatment of neonatal seizures is time sensitive. And there are two studies looking at this in more detail. So this is a study from Utrecht, and they found that only around 30% of babies were treated within the first hour of seizure onset. And that was confirmed in the Answer 1 trial. It was even worse. Only 10% of these babies were treated within the first hour. Far more were treated after. So here, these are babies treated in the first hour, 1 to 2 hours, and then more than 2 hours. But if the babies in the group who were treated within the first hour had an overall significantly lower seizure burden than the babies who had a seizure were treated later. And this is most clearly seen in the status epilepticus group. So babies treated within 1 hour of seizure onset, very few progress to status epilepticus. If you treat after 2 hours, there's a much higher number of babies progressing to status epilepticus. So one thing is really, we should treat as early as possible. What drugs? That's the second question. So what do we use at the moment? Well, this will not surprise you, but there have been a number of surveys looking at what drugs are used, and really worldwide, phenobarbital is #1 in all these studies. There was a brief period around 5 years ago where many people preferred levetiracetam, but this has changed again, and I'll come back to that. Second line varies considerable, and there's really no agreement. Levetiracetam, phenytoin, benzodiazepines, or lidocaine. What's the evidence? So is there any evidence to use phenobarbital first line? Or is there any evidence which drug to use a second line? There has been a Cochrane review in 2004, which is currently updated. And that Cochrane review said there's little evidence to support the use of any anti-seizure medication. In 2011, that has changed a bit. Phenobarbital was recommended, the only drug recommended, but with very low evidence. And there was no evidence for the use of any other anti-seizure medication. So again, both of these are updated at the moment, and we finalized the update of the ILAE guidelines, and I'm going to present them in a minute. Okay, so that means we have phenobarbital, and the question is, why do we still use phenobarbital? These are the anti-seizure medication developed for older children and adults, mostly adults. And you can see over the years, there are so many. We are now third generation anti-seizure medication. Many of these have been widely tested and licensed for adults. If we look at neonates, then we are here with phenobarbital, which was developed late 19th century and then introduced for seizures over 100 years ago. Phenytoin is also somewhere here, benzodiazepines. Why do we still use these old drugs? And the problem really is that doing drug trials in neonates for seizure medication is extremely difficult. There are so few randomized controlled trials. There are, I think, about 5 randomized controlled trials which have been done with EEG for neonatal seizures, and which is in contrast to hundreds, maybe thousands for older patients. And it's because they're really difficult to do and very expensive. And I'll just want to go through some of the challenges associated with neonatal drug trials, or specifically for anti-seizure medication. So we know that there are age-dependent mechanisms for neurotransmission. So here are preterm babies, also post-gestational age, from very premature to adults, and you can see how the neurotransmitter change over this time. And particularly, there is an overexpression of excitatory neurotransmitters in neonates. And that's true for animals, but also for humans. Plus GABA is in the neonatal period possibly inhibitory, or at least some of the GABA receptors are excitatory rather than inhibitory. So there's here you see GABA depolarizing and GABA inhibitory. So in adults, inhibitory; in neonates, at some point, there's a switch from excitatory to inhibitory. But when that is, we don't know. It could be that it's way before babies are born, but we don't know. But this means really that it's difficult to use adult drugs. We cannot use drugs developed for older patients and older children easily and use them for neonates because the mechanisms might be different. There's an ethical predicament. I mean, you all know how it is. Babies are born. Most of these babies have an insult nobody knew about. The parents are overwhelmed with a baby on ITU, and then they have to make a decision whether they want this baby to be enrolled in a trial. Plus, usually there is no time. So normally if you do an anti-seizure drug trial, you give the parents or the patient a patient information sheet, you send them home and say, you come back in 4 weeks, you read it, you think about it, and then you decide whether you want to be enrolled into a study. These patients or the parents, they have no time. They need to make a decision within 5 or 10 minutes. And that is really difficult. Plus, babies are vulnerable, like all children. To make a decision for your child to be enrolled into a drug trial is very difficult. In addition, neonates are critically ill. There's a high comorbidity, which means that there are many adverse events which you would not see in older children. And I want to very briefly tell you about our lessons learned in the NEMO trial. So the NEMO trial was a drug trial we did with metamide. It was an FP 10 years ago. And so the idea is that, as I said earlier, GABA is normally inhibitory, but in neonates or in an immature brain, excitatory due to a high expression of the NKCC1 cotransporter. So you have a high intracellular chloride, GABA dox, and then is excitatory, whereas in an adult or more mature neuron, you have low intracellular chloride due to high expression of the KCC2. And then GABA works inhibitory. And the idea is that bumetanide, a diuretic, is NKCC1 co-transporter blocker. So it makes the immature neuron react more like a mature one, and then you have GABA working inhibitory, and you can give phenobarbital. So we did this study as a combined dose finding and efficacy trial. And after 14 patients, we paused because within 14 babies, we had 3 babies who developed hearing loss, which is far more what you normally expect with HIE. It wasn't significant because 14, the number is too small, but we looked at it in more detail, and what we thought the theory is that you have a multiple hit. So you have this is the cochlea, and you have immature stereocellular, you have ischemia in babies with HIE, you have aminoglycosides, you have a hypoxic injury which damages the membrane, noise injury, and then bumetanide as well. So whereas in older patients, bumetanide is very unlikely to cause hearing loss due to the immaturity and the comorbidity in neonates, the risk seems to be much higher. And therefore we stopped the trial, we terminated the trial. None of us were willing to continue to enroll into this trial. The other thing we learned is that actually, so we have 14 babies, and we looked at the effect on seizures. And we realized it was really difficult to come to any conclusion. So here you see the seizure burden in those 14 babies. 0 is the time bumetanide was given. In black is when the babies had rescue medication. And what you can see is seizures fluctuate. They are not there all the time. They come and go. And so you have a baby with seizures on EEG, you decide to enroll this baby into this trial, and then by the time you give them bumetanide, the seizures have stopped and they don't come back, but you don't know whether they don't come back because you have given bumetanide or because they fluctuated and stopped anyway. So in many of these babies, they were actually given when the seizure burden was dropping down already. In some, they came back, and then 12 out of 14 babies needed rescue medication. So even though there was, in theory, a reduction of seizure burden in 5 out of those 14 babies, 12 had rescue medication. So we can't really say which of those babies responded to the bumetanide. And overall, we concluded that there was no additional benefit in all of them. But it really highlighted the difficulty in defining a proper outcome measure in neonatal seizures. Then there are the logistic difficulties. I've discussed this earlier. So neonatal seizures, the clinical diagnosis is unreliable. You need EEG or AEG to diagnose the seizures reliable. And for a drug trial, the outcome measure, it's really important to measure them precisely and accurately. So clinical diagnosis is not possible for drug trials, and AEG also not. So, and the reason why clinical diagnosis is unreliable is because you have non-seizure behavior which has similar semiology to seizure behavior. And the sensitivity and specificity of AEG, as I said, is not good enough for drug trials, even though it's used in clinical practice. And then lots of babies have electrographic only seizures. 50 to 70% of all seizures are electrographic only, so without any manifestation. Here's a baby in status epilepticus without any manifestation. And the reason why you have such a high percentage of babies with electrographic only seizures is because these babies are critically ill, they're on muscle relaxation, they're sedated, and then there is a phenomena which is called uncoupling, which means that here you have a baby with an electroclinical seizure. So here you see a clonic seizure and the EEG confirms that this is a seizure. And then the baby was treated with phenobarbital and there are no clinical manifestation, but the seizure continues here on EEG. So the manifestation of the seizure gets uncoupled due to medication, anti-seizure medication. And we know that phenobarbital and phenytoin cause uncoupling in at least in around 40 to 50% of babies. And then there is the timing of the evolution. So the definition of outcome measure, I mentioned this earlier, is important to define the outcome measure properly, but it's a difficult thing, so you need to evaluate over a certain period of time, but you also need to think about the timing. These are babies with HIE. This is a study by Geraldine Boylan from Geraldine Boylan's group. And so babies born, and then here's the age in hours. This is before cooling and this is with cooling. And what you can see is that the seizure burden, seizure onset is at around 6 to 8 hours. And then the seizure burden increases with a peak at around 24 to 36 hours, and then it drops down. And so at 72 hours, most babies are either seizure-free or have a very low seizure burden, which means if you give the drug at some point here, you will think the baby responded, but what it is the natural evolution of the seizure burden. So actually, if you do a drug trial with an HIE with seizure medication, you can only include up to 24 hours or maybe 36 hours. Because anything later, it's the drug, we don't know whether it's the drug or just the time evolution. The other problem is that recruitment into drug trials is really difficult. I mentioned this earlier, parents are stressed and doctors don't have time, nurses don't have time. But then there's another problem, which are the patient information sheets. So any of the drug trials done by pharmaceutical companies, the patient information sheets are 20 pages long in small print. I don't know, font size 8 or something like that. This was a drug trial I was involved in with brevitaracetam, the PETIT study, and this is the patient information sheet. Even I didn't understand this patient information sheet. It was so complicated and really threatening because you had to sign things in a language I wouldn't understand, all the legal terms, and so long, I mean, to understand all of this, to read it, understand it, while you're worrying about your baby is sheer impossible. And we discussed this for hours and hours, and they said they have no other option. Their lawyers wouldn't allow them to use a shorter patient information sheet or a patient information sheet that is more friendly to the patients. So this study enrolled a total of 6 patients and then terminated early because they couldn't recruit. And I'm not surprised, to be honest. There are other options. I mean, you can do patient information sheets differently. We are currently doing the EAGLET study. It's not a treatment study, but we're using graphic information sheet, and the parents prefer this. You still have the consent form and you have some writing, but it's much less and it's less threatening, and they can understand much better, even in these situations, and there they are. So all of this means these studies are extremely expensive, but have very low returns. So pharmaceutical industry is not really interested in supporting any drug trials for neonates. And that really explains why there is so little. Having said that, we still need guidelines. And as I mentioned earlier, there is evidence if there are good guidelines in a neonatal unit and you treat according to protocol, you can speed things up and and improve the response to medication. So because the last two guidelines couldn't really recommend anything, and there has been several changes, cooling came in, plus there were several new drug trials, the International League Against Epilepsy decided to update the guidelines, and we have done this over the last few years. We did this according to the guidelines of guidelines, all according to the regulation. So first we formulated the priority questions according to PICO, and these are the priority questions we came up with. So first line, anti-seizure medication; second line, when to stop; effect of therapeutic hypothermia; treatment of electrographic seizures; and the use of pyridoxine, pyridoxal 5-phosphate. Then we initiated a multidisciplinary international working group, and you can see we have neonatologists, neurophysiologists, neurologists, patient representative, methodologists. It was a huge group, and it was great to have these different experts, and really the only way to do this. Then we identified the evidence. We screened nearly over 2,500 abstracts, and then included 218. And this is the flow chart. And then we evaluated the evidence with grade. But there were really only 3 of the priority questions where there was good enough evidence to use grade. So for the other priority questions, we did an expert recommendation using the Delphi process. And we had 3 rounds of questionnaires. And then we formulated the guidelines. So at the moment, we are really, actually, we just sent in the last revision. So hopefully this is going to be accepted within the next few weeks, and then in print too. And I just wanted to briefly go through what time did I start?
You've got half an hour.
Thank you. I wanted to go through those guidelines. So first line, anti-seizure medication. There were 2 randomized controlled studies, 3 prospective studies, and 6 retrospective studies. So we did the grade on the 2 randomized controlled studies. One is the Painter study, which compared phenobarbital with phenytoin. So here they had phenytoin and phenobarbital, and the babies who didn't respond then had second line, the other drug on top of it. The certainty was low. There were lots of confounding factors, but they found seizure freedom in both of them in around 40 to 50% of the babies. And then there is the Sharpe study, the NeoLEV-2 study, which is a really well-conducted randomized controlled trial comparing levetiracetam with phenobarbital. And this was, they started around 10 years ago at a time where everybody was talking about levetiracetam. It was sort of lots of hope that this was a drug which is effective with very little side effects. It has a very good pharmacokinetic profile and few side effects. And because everybody was so convinced that this drug would change everything in neonatal seizures, they randomized 2/3 to levetiracetam and 1/3 only to phenobarbital. And what they found was that, so they give 1 dose and then the second dose. With phenobarbital, 80% were seizure-free, whereas with levetiracetam, even after a second dose, only 28% became seizure-free. So the efficacy of levetiracetam is really not very good. And the certainty is moderate, which is for a randomized control trial very good. So, we also did a Delphi to see whether there is any recommendation which drug to use. And for which etiology the phenobarbital should be used, whether there is any preference for different etiologies, and we all agreed phenobarbital should be first line regardless the etiology, with only one exception. If there is a family history for channelopathy, so KCNQ2 and epilepsy or SCN2A, if there's a family history, so you're certain that this is why the baby has seizures, then a sodium channel blocker should be used, which is phenytoin or carbamazepine, but really only if there's a family history. Second line. So again, we had 3 randomized controlled studies, the Painter study, the Sharpie study, because they then added the other drug on, and the study which we did at King's, Geraldine Boylan's study. The problem is all of these have very low certainty because they are because numbers are very small for second line. They were better for first line, but not very good for second line. Plus, so we couldn't do a Delphi because the certainty was so low, and we couldn't do a grade. And so we did a Delphi, and after 3 rounds, we couldn't get to an agreement. So here you see the different anti-seizure medication. We agreed that over 66% would be an agreement, but we argued, we discussed which one we preferred, we reduced the number of drugs we included. There was just no agreement. Phenytoin and levetiracetam were the favorites, that's no question, but which of those 2 is better, we couldn't agree on. The only exception is in babies with cardiac disorders. Levetiracetam is the preferred drug according to experts because phenytoin and lidocaine are both cardiotoxic. And then also if you have a suggestion for channelopathy because of the EEG findings or clinical presentation, then sodium channel blockers should be used. But otherwise, really, there was no agreement. So these are the recommendations. Phenytoin or levetiracetam may be used as second line. Other options are midazolam or lidocaine. Only if you suspect a channelopathy, then phenytoin or carbamazepine should be used, or if you have a baby with a cardiac disorder, levetiracetam is a preferred drug. Here, I just want to tell you a bit about a study we have done recently, and these are very new results. So, as I said, nobody really knows levetiracetam or phenytoin, and the difference is really quite dependent where you live. In the United States, most people prefer phenytoin, whereas in Europe, most people prefer levetiracetam. And so the PREVENT study is a study we have, which was done in India. It's prospective observational study for the implementation in the birthing process. So it was implementation of how to support the mothers, and one of the outcomes was encephalopathy and seizures in babies. So this is sort of a nested study within the PREVENT study. And what we did is we looked at how many babies responded to second-line medication. So all of these babies had EEG monitoring for 4 hours when there was a suspicion of seizures or encephalopathy. And we gave medication, first phenobarbital, then levetiracetam, and then phenytoin. So it was according to protocol. And we looked at the responsiveness, first levetiracetam, and then phenytoin. Most of them had phenobarbital before EEG was started, so we can't look at the efficacy. And so here you see 3 examples. So here's a baby with seizures who first had phenobarbital, then levetiracetam, and here the baby responded to levetiracetam, and there was no need to give any more medication. Here is a child responding to phenytoin. So here phenobarbital, levetiracetam and then seizure-free on phenytoin, and this baby didn't respond to anything. And these are the results. So we included 150 babies, a really high number of babies compared to most other studies. And here is levetiracetam. 14% responded, whereas the third drug, so the drug which is in theory even disadvantaged, we had a seizure freedom of 55%. And this was even more obvious in babies in status epilepticus. So we had 47 babies in status epilepticus. None of them responded to levetiracetam, and 43 responded to phenytoin. So I think, I mean, now I think I also used to say levetiracetam better, sort of less side effects, easier to give. With these data, I think it changes the way I think about phenytoin and levetiracetam. Next priority question, when to stop anti-seizure medication. There were no randomized controlled studies, 1 prospective and 2 retrospective studies, plus 1 study outside the time frame. Obviously not enough to do a grade on this, so we did a Delphi. This study came out in 2021, so it probably affected how we voted in the Delphi. And basically what they did, this was a prospective observational study, and they compared babies where they continued anti-seizure medication outside the neonatal period to babies where they stopped it before the baby was discharged from the hospital. And in prolonging treatment outside the neonatal period did not reduce the risk of later onset epilepsy and did not improve outcome. So really what it means is anti-seizure medication should be stopped if a baby is seizure-free. Obviously, if a baby continues to have seizures, then you mustn't stop. And this is either electroclinical or electrographic seizures. Without the onset of neonatal epilepsy, anti-seizure medication should be stopped or discontinued before discharge home. And in contrast to previous guidelines, we say regardless of EEG and MRI findings, because all of these babies have abnormal EEGs or MRIs. If it's acute symptomatic, you have a brain insult, and of course the EEG will be abnormal. So regardless the EEG and MRI findings, unless you have seizures in the EEG, medication should be stopped. Effect of cooling, there were no randomized controlled trials, but a few prospective studies. So some of them were done really well, so they could be upgraded, and we did a grade. But of course, because they were not randomized controlled trials, the evidence is very low. And we did a Delphi on top, so both the grade and our Delphi concluded that there's evidence that therapeutic hypothermia reduces seizure burden. Number 5 is a reduction of electrographic seizure burden associated with improved outcome, or should we treat the EEG, should we treat electrographic seizures? It's a very controversial question. And so we looked at the evidence. There are 10 studies. 2 of them were randomized controlled studies. So this here, and this was the study in the States and another study in Utrecht, both of them underpowered. They couldn't recruit enough patients into this study, mostly because the parents were not willing not to treat the seizures when they were seen on AEG or EEG. There's another study, the Hunt study, which was published outside our time frame. Again, this study was underpowered, plus what they didn't look at whether reduction of seizure burden improves outcome. They only looked at whether giving the baby anti-seizure medication, regardless of responsive or not, improves outcome. Of course it doesn't. So didn't really measure the outcome measure they implied they would measure. But it was outside the time frame anyway, so we did a Delphi, and we had moderate agreement that electrographic seizures should be treated the same way as electroclinical seizures. And then finally, the use of pyridoxine or pyridoxal 5-phosphate, no randomized controlled studies, 8 retrospective studies, that they were case report studies. So we did a Delphi, and we agreed, we had a really very good agreement, a trial of pyridoxal 5-phosphate add-on to anti-seizure medication should be attempted in any babies presenting with clinical features or EEG characteristics of vitamin B6 dependent epilepsy, and in babies not responding to second-line medication without a clear diagnosis. And then we had a few additional recommendations which we only looked at using Delphi. The need for standardized treatment, obviously 100% agreement. The need for communication with parents and guardians on the condition of the baby, and the use of anti-seizure medication, again, relatively high agreement. And then we agreed also on a treatment plan as an example, treatment plan and the dosage. And these are a suggestion of a treatment plan according to our evidence and Delphi. So these, as I said before, hopefully these guidelines will be published very soon. And before I finish, I just want to very briefly talk about a few gaps which exist. So first of all, thinking about what Andy said, new drugs, I looked at clinicaltrials.gov to see what trials are ongoing or what has been used. And so there's really very, very little. I looked at the different drugs. So levetiracetam, there were in total 7 studies. 4 of them are still ongoing. But to be honest, I'm not so expecting any better results than what we have at the moment. Topiramate is a drug which there was 1 case series in 2015, but it was just retrospective, and 1 neuroprotective randomized control trial, but they didn't actually look at seizures. They only looked whether the outcome would be improved if topiramate works as a neuroprotective agent, and it didn't. But they didn't do EEG, they didn't measure the seizure burden, so we don't know whether it works as an anti-seizure medication. Bumetanide, I've told you about the NEMO trial. There's also the Harvard study, which was published by Janet Soul a couple of years ago. And their study was a randomized control trial, but a dose-finding study. And they had some kind of very complicated calculations of the seizure burden and found that it improved seizure burden, but you can't really, they didn't present the seizure burden before and after, so nobody can really understand the calculations they made. And when we included the study in the Cochrane review and did the calculations according to the Cochrane tables, there was no improvement. So I'm not sure. I don't think bumetanide is promising. There's also some evidence that it doesn't actually cross the brain-blood barrier. Brevitiracetam, this is the PETIT study. As I said, the study was terminated due to failure to recruit. But in addition, brevitiracetam works very similar to levetiracetam. So I don't see anybody doing another study for efficacy. And then there's 1 study ongoing for lacosamide, which runs in the States. But again, lacosamide is not really used in status epilepticus. Oh, it is sometimes, we'll see. That's the only ongoing study. So there are lots of gaps. we can't really extrapolate from adult data or older children because of all the mechanisms I told you about. So it's really a limited option. And so there is really a lack of randomized control trials, and the studies which I've done, only very few have a very good, precise outcome measure. There's a lack of safety reporting, and that's a really, really big issue. Many of these studies don't report safety at all. They don't use standardized safety reporting, and none of those studies use long-term outcome, which is desperately needed. There hasn't been done in any study to look at when to start treatment. So what is the minimum seizure burden? The International Neonatal Consortium suggests to use 30 seconds, a seizure burden of 30 seconds as a starting point. But really, this is just experts thinking what could be, because there's no study looking at this at all. As I told you, there's only limited data and evidence on second-line medication, and there are no studies with long-term outcome. So in summary, the diagnosis and treatment of neonatal seizures is time sensitive. I think this is something we can really say now. Phenobarbital is still recommended as first-line drug, but it should be short-term only. Second line includes levetiracetam and phenytoin, but there is no real evidence which of them is preferable. And prophylactic treatment beyond the neonatal period is really not recommended. And we need more randomized control trials. So in summary, really, it doesn't very much go beyond phenobarbital and phenytoin. And I'd like to thank everybody in the task force. It was huge work, and it was fantastic working with all these experts together. Thank you.
Thank you, Ronit. That was super, absolutely super, and a very clear walk through what is quite a lot of complex data and some firm recommendations which we can take home. And this is a clinical problem that those in clinical practice are dealing with every day, and those guidelines are very clear. You're hopefully coming out soon.
Yeah, hopefully in epilepsy.
Thank you. We do have time for questions.
Hi, Tim Van Hussel, University of Leicester. Thank you very much. It was a really excellent presentation, and yeah, really clear summary. And I was just thinking, you touched on mainly term babies with HIE, and then there's preterm, IVH, sepsis, all of those, things as well.
So
I was just wondering, given all those drugs, do we need to return to animal models to try and find some that are more effective before trying more RCTs that are as disappointing as the levetiracetam ones?
Yeah, I'm not sure. I mean, in theory, if you look at all the drugs which have been developed, they should have been tested in immature animals too. How much that is useful, I mean, for levetiracetam, the animal data was great. And it even suggested neuroprotective actions, but it doesn't translate into clinic. So I think the key issue is really to do good clinical studies for drugs which have been developed for adults and older children. I mean, yes, animal models is a great idea, but and definitely also needed, but it's only part of the problem. Many of these studies actually have been done in HIE and other etiologies, acute etiologies, so sepsis and everything. So that I would include in there.
Just got one question. Sorry to take those. So I got a question from Naz Merchant, neurologist. Thanks, Ronit. Our neurologists are very consistent in slow weaning seizure medications in the neonatal unit. Do we need to do this?
Good question. So it depends a bit how many drugs and how long the baby was on it. If you give a baby phenobarbital for 2 days, you can just stop because the half-life is so long, the baby weans it himself or herself. If a baby was, on the other hand, on 3 drugs for 2 weeks, then yes, never stop everything together, one by one. And midazolam always has to be weaned. Regardless how long you gave it, you have to wean midazolam, because otherwise you get rebound seizures. And if phenobarbital was given for a long time, then again, possibly yes.
Thanks, James Boardman, Edinburgh. Thanks for sharing these new data about the Indian trial of phenytoin versus levetiracetam. Could you confirm that the groups were equally balanced for seizure burden at the time of randomization?
So this is not a randomized trial. The Indian data is an observational study, and all babies had first levetiracetam and then phenytoin.
Oh, I see. Okay.
So it wasn't a comparison. It's not independent data.
Okay. Important before levetiracetam is consigned to history books.
Yeah. No, but in theory, it should mean that phenytoin was disadvantaged if you compare them, because it's third line. And we know that first line works always best, then second line, then third line goes down. And so even though phenytoin was third line, it worked so much better.
And just coming back to your last recommendation around more RCTs, what are your thoughts around stratifying by seizure burden at the point of randomization in any further RCTs? Is that necessary? And what level of seizure burden would you think should be included and excluded?
Yeah, I mean, I think seizure burden is really important. I'm all in favor to reduce the numbers. So I think status epilepticus, for example, what we call status epilepticus in neonates, that's a very, very old-fashioned and conservative compared to older patients. The International League Against Epilepsy has reduced, it was 30 minutes before of an hour, more than 30 minutes, now it's more than 5 minutes. And we are still stuck with 30 minutes. So I think there's a real need to reduce that, particularly with the data showing that a seizure burden of more than 10 to 12 minutes is associated with poor outcome. So I definitely be below 10 minutes. But I think stratifying is good, particularly because they respond differently. If I have a baby with a high seizure burden, it will respond differently.
We have another online question here from Katie McKinnon. Thank you. Can I ask about the timing of starting treatment? Do you mean with only 30 seconds of seizures, treatment should be started? This is quite different from many guidelines and from treatment management in other age groups.
Yeah, it's difficult. I mean, 30 seconds, the problem is that you have, the longer you wait, the more difficult this is to treat. So at what point do you miss the boat? And we don't know. There are no studies looking at it. I think 30 seconds might be a bit too short, but when you get to a minute, it's probably then at some point getting too long, because then the seizure burden is too high and the seizures gets established. I don't know, but there's no data. I don't know. Nobody knows.
A lot of additional monitoring that's going to be needed in diagnosing seizures to pick seizures up so early in the at-risk groups who are a significant number of babies in those groups, of course.
So I think we monitor everything. We monitor the heart rate, the respiration, the blood pressure, everything, and we don't monitor the brain. Talk to parents what they want.
Pollyanna, and then.
Thank you, Ronit. That was really interesting. My name is Pollyanna Harding from the National Perinatal Epidemiology Unit at the University of Oxford. Always a bit of a mouthful. We co-authored a paper together with a larger team and under the International Neonatal Consortium on the recommendations for the design of therapeutic interventions for neonatal seizures. Be interesting to know whether you feel that's had an impact on trials being carried out, but also given the difficulties in carrying out trials in this area. What do you feel are the priorities in terms of what work needs to be done to facilitate trials being carried out in terms of acceptability and the design issues and so on? Is there some preliminary, additional work that we all need to be thinking about here?
Yeah, I mean, I think the 2 or 3 real main issues. One is that it's so expensive, and this is not something we can do. They're really, really expensive trials, and there's something that the funders need to change. I mean, they need to see that this is a priority, and they need to fund these studies, even though they're very expensive. The other thing we need to do collaborative studies. I mean, even though seizures are common, they don't occur often enough in one single unit. So even if you have 2 or 3 units, you need really 10 units to work together. And all of them need to embrace the EEG, because without EEG, you can't do drug trials. EEG is good for clinical practice, but doesn't measure seizure burden exact enough. And so setting up EEG in the neonatal units is so difficult. I mean, the EAGLET study, we started 2 years ago, and we're only about to start because of the logistic difficulties. I think, yeah.
One last question.
Hi, I'm Sarah Sparrow from PRM in Glasgow. Just remembering some of the work that Geraldine Boland has presented with regards to timing of onset of seizures. I find that really interesting because that can perhaps show or give some indication about diagnosis or causation. In terms of how, at what stage the clinical seizures may present, in the first 6 hours, 24 hours, for example. And I wondered what you thought about that in terms of, again, using that for directing a study and treatment.
Yeah, I mean, Geraldine and I work very closely together, and I mean, this is the way we planned the NEMO trial. So really, you should include babies within 36 hours of birth if you look at HIE, and with stroke or any other etiology within 36 hours of seizure onset, very clearly. Yeah. I think with HIE, even more so, it's if you have seizure onset before 6 hours in HIE, there might be comorbidity, because normally, I mean, the animal experiments suggest that you have a seizure onset 6 to 8 hours after the insult and not before.
Thanks.
Final question from Nikki.
Ronit, thank you. Fantastic. I missed the first part. I'm sorry. You've said how expensive clinical trials are, how difficult they are, and how long they take. But in the same breath, we're also saying that animal models aren't up to it and shouldn't really be done so much.
No, I take that. No.
Can I just say that we can't lump animal models all together, because I think you have to think of the gyrencephalic models, such as a piglet, where you can have full neurocritical care, full EEG, and the brain development is exactly, well, very similar to the baby. Whereas the NEMO trial is very much based on rodent data, and as we know, development is very different. So could I please make a plug that actually animal models, if you use the right model, will inform the clinical trials?
My apologies, absolutely right. I couldn't agree more. The right model is very helpful, and I think any drug developed needs to be first tested in animal models, and the right model needs to be used. There is no question. I didn't mean to say that we don't need models, but I think we can't. What we did in the NEMO trial was we went from animal model, rodent model, straight to clinical, and that shouldn't be done. No. That's what I meant. I think we need animal models, but we need also, I mean, with NEMO, it was a bit difficult because you can't even go to adults and infants. Ideally, if you have a drug as an anti-seizure medication, it should be done in the animal model. And if it's a drug which also works in adults or children, it should be tested on adults and children first, and then go to neonates. But sometimes it doesn't work because if it's precision medicine and we have a drug specifically for neonates, then that's what we need to do. But I fully agree.